Thank you very much. This is a very important session, mainly because it's the last session before your lunch. So I think you're very eager that this finish early. The title of this session is Perspectives on the Patient at the Heart of Care. There are two perspectives here. The first is the advancing connected health to improve patient engagement. The two speakers will touch on how can organizations design and implement connected care programs that produce results for patients and providers. And the perspective number two is unlocking the pharma value chain. I will hear the speakers speaking on the potential for tech to meet touch to deliver value at the practical inflection points in the pharma value chain. We have 4 speakers, and each speaker will be given 10 minutes to speak, and they'll be reminded 2 minutes before the end of the 10 minutes. And thereafter, we open the floor to Q&A. I would just like to quickly introduce the speakers, the 4 speakers. The profiles are actually in your pack, so I won't read all of them. But I just want to highlight the salient points. The first speaker will be Dr. Muhammad Khadzir Sheikh Ahmad. He is a doctor, being a medical doctor, qualified medical doctor, and also with a PhD in occupational health from the University of Birmingham. He is now leading the development of the Malaysian Health Data Warehouse, also known as MyHDW. The project was developed using more than 90% local technology and was rolled out in 2016, launched by the then Health Minister in April 2017. He will speak on the connected health, the experience on MyHDW, and I believe that the phase 2 of the MyHDW has just been concluded, and now continuing with the utilization of the system to bring data into the MyHDW and preparing for the big data analytics. So I think the system is going to pull data from government hospitals and clinics, and also private hospitals, and also the GIS, which is a geographic information system, so that covers pollution, weather, and environment. The next panelist will be Tirupathi Karthik. He's a CEO of Napier Healthcare Solution Private Limited since November 2016, a leader in healthcare IT space. I think you have a lot of experience across Asia, Middle East, and USA. And you will be speaking on the Napier's RPM, which is the remote patient management. And you also cover the buzzword nowadays, which is IoT, Internet of Things, AI, and also machine learning, which I would assume you'll be covering Dr. Google as well, which a lot of people are using. All in 10 minutes, yes. Then we have the third panelist, Amrahi Buang, who is the current president of the Pharmaceutical Society, MPS, the recognized national professional body for pharmacists in Malaysia. He has served 35 years at the University Malaya Medical Center as the chief pharmacist and the deputy director of professionals. So I think he will be speaking as an expert. And I think you also you're very well involved in the halal pharmaceutical standards, halal medical device standards, also the first in the world, and also a certified halal trainer. And perhaps you may want to touch on a very sensitive issue now, which is the halal vaccine. The last panelist will be Leonard, Ariff, Abdul, Shatar. He's got a degree in law and economics, a double degree. I think you have been the managing director of Usaha Pharma, the CCM. I always call it CCM, so I've got to add a Berhad now. CCM Berhad Pharmaceutical Retail Arm. You got a lot of experience, really. He was also the president of the Malaysian Organization of Pharmaceutical Industry, MOPI, from 2009 to 2014. And on the radio this morning, I'm not sure whether you heard, on BFM, Breakfast Grill, the MD of Pharma Niaga was grilled really on the BFM grill, Breakfast Grill this morning. So I don't know whether you want to touch on this, some of the issues that arose from the interview. So with this, I'd like to invite the first panelist to speak. Go to the slides there.
Assalamu alaikum warahmatullahi ta'ala wabarakatuh, and very good morning. First of all, my thanks to the organizer for inviting me to speak. And I'm talking about Malaysian Health Data Warehouse. And I need to clarify, in terms of connected to health, we are not directly connected to every patient that we see in our healthcare facilities. Healthcare Data Warehouse is about collecting of secondary use data, and the main purpose is about statistic, and these are mainly used for the purpose of evidence-based decision making. Okay, it's very important that when we develop this system and when we launched that, there was a confusion about security and privacy of the data, and that is very utmost in our principle when we deliver that. And we work very hard to identify the provider of the technology, and MIMOS has been chosen through our evaluation to be the provider of the technology. So MIMOS has a lot of platform, and we initially developed the data warehouse the first time. Data warehouse all over the world. Malaysia is the 7th country, but the first country is to use our local technology. So we have one assurance that this is local provider. So maybe we can somehow take care of the security at that level. Yeah. Number 2, we subscribe to all the requirement which is about privacy and security. So we refer to RAKSA, which is the MAMPU guideline, and we follow all the requirement so that we are comfortable when we deliver the system that ensure privacy and security. Yeah. So Malaysian Health Data Warehouse is about collection of visit data to any healthcare facilities, be it the clinic, be it the hospital, and then be it the daycare center and whatnot. And that is very important. So if you can subscribe, or you are the user then that can log into the system, this is our landing page. Okay, so it has got some thing that you cannot see here. Let's see. Okay, it is here. It has got these two first part, which is the data collection, and the rest are the visualization. So what we are trying to say here is we try to minimize the work that you do. You collect once, and the rest are visualized into our MyHealth Data Warehouse that deals with the fixed format report and the query. And then we bring the data to Geographic Information System. And if you bring with you the discharge summary data, unstructured form, you were able to analyze the unstructured form and generate a KPI for you. Okay, and last but not least, also statistic and predictive analytics. There's a lot of users who wanted to use the data inside. Rather than taking the data out, they can go into the system and use the data using our pre-prepared statistic inside the system. Okay, so that is as much as we want to protect the data inside by ensuring that it doesn't go out. That's one. And coming into the project is about virtual environment, because there are many requests from the researchers who wants to use the data and brings their own data. So what they can do is they can go into that virtual environment, they can bring our data into their virtual environment and bring their own data into that virtual environment. And this is basically to ensure that data never goes out and protect the privacy and security of the data. Okay. Let me refer to the data collection system. We have two. For every visit data to any healthcare facilities, we have what we call Sistem Maklumat Rawatan Pelanggan. Okay. If you go to the hospital, there are so many modules. We have the inpatient, we have the daycare, we have the 10 clinical support groups, and then we have the procedure rooms dan sebagainya. Okay. For the clinical support group, we have the physiotherapy, occupational therapy, we have the speech, audio, and then the pathologies, the radiography, and also the lab that goes into the data goes into the system. Okay, so this is very rich, but this is only about basic visit data that goes into the system. So with that basic information that goes into the data warehouse, we can link a finding from the outpatient to the inpatient and to the daycare. And we can analyze to give some of the information that we require. Okay. So that is about structured data. And with this system, we are able to cover it, and we are encouraging all hospitals to participate. So one of the perspective is we cover all healthcare facilities, and they come from Ministry of Health, they come from the private hospital, they come from the army, and they come from the university hospital. So that is the first spectrum. The second spectrum is we cover all services within the hospital. You go to the hospital, they got the inpatient, they got the daycare, they got clinical support, they're all included, and all visit data from that services is covered. And the third one, and not the least, but the most important one, is 80% of the data comes in the form of unstructured information. So you have the discharge summary, you have the pathology report, and whatnot. What we were able to do, and thanks to the technology in MIMOS, we developed the AI component, knowledge-based learning, where we were able to analyze the discharge summary. The challenges that was provided to us was, they gave us IJN, and they gave us discharge summary from IJN. We are now able to generate KPI from the discharge summary to be given back to IJN, and normally they take about 3 years to generate such KPI. But with the discharge summary that they gave us, we can do that every 24 hours. So that was the technology that we managed to deliver for them, specific for cardiology. Okay. And then we have a second group, which is yellow. Okay. So the blue was chosen because this is supposed to be universal. All patient visit to the hospital, they come in blue color. But the patient registry information system is on the Hermé color, which is orange. They're slightly on the posh groups. They are led by the private investigator to the government on specific registry. So what we have included in our first rollout was the cancer group of patients. There are 15 groups of cancer, and they use the patient registry to enter and monitor the patient development. And what we have done in that patient registry is we can generate a population-based registry. You know, every time they send a notification for the cancer group, we can generate the incidence and prevalence for that purpose. Okay? And after that, they can view the patient and they can generate whatever information they require with regards to the nature of treatment, best treatment, and so on and so forth. Okay? And that is through single data entry, meaning to say, every visit goes to SMRP. Once notified in SMRP, the data will flow into PRIS. Okay? If this is a group of cancer. Once notified into PRIS, for every subsequent visit to the healthcare facilities, the data will automatically flow into the system. So you get your data and you can enrich your data from your own personal visit and you see them in patient registry information system. Okay? So we are trying to capitalize on that availability. And after that, from SMRP and PRIS, they will go into Mahal Data Warehouse and they will generate the standard fixed format report. You can do a query on your data and you can do predictive analytics. 10 minutes. Oh, that's already 10 minutes. Okay. And then, beside that, we also have GIS, we don't have to key in the data again. Once you key in, we will pull in your data. For example, for every hospital, we just pull the figures to you so that you can visualize the finding inside the GIS. This is how we try to limit our data entry processes. And also not only to limit data entry processes is to make sure that the data we key in once, these are all applied throughout the various visualization inside the system. Okay. I already mentioned about my harmony. We did a test on the statistic predictive analytics. We were working with the Department of Environment, and then we linked that up with the discharge data. And they have got the point of collection for the pollution index. And we worked with one of the university from Tokyo. What we found was, for every discharges and KPI that is being generated, they can do a predictive analytics study. And what they can demonstrate to us was the amount of saving to the government from the number of discharges that we can reduce with the going down trend of the air pollution index. We can do that. So that was the exercise we did before, and we look forward to many more case studies on the predictive analytics that we can do. So this is possible. What is important to highlight here is every time data on each patient goes into my health data warehouse, we will split the demographic data from the clinical data. Okay? And the demographic data is anonymized. That's very important. Nobody knows who is who inside the data warehouse. But we can link the data inside the data warehouse to another database if we were given the same anonymized demographic data. Okay. So it is quite safe once you are inside data warehouse, but we can always go back and ask the bosses to give back the key so that we can de-anonymize those patients. But I think that is the last thing that we would like to do. Okay, so we wanted to provide the assurance that data is protected in terms of security, in terms of privacy and whatnot. And there's a lot of interest to use the data. We have Data and Information Governance Committee. They have to go through that committee, and we are now having all the guidelines on who can be the users to the system. Okay? So it's not about me, it's not about Health Informatics Center who provide the access right. There is a governance committee that oversees the whole process. We are also establishing the data and information quality framework to make sure that we provide quality data. Okay. And then we work independently with the security committee inside MIMOS, who will oversee the development inside my health data warehouse to make sure these are secured. And we are now trying to work because it costs money, with some international agency to see whether people can hack into the system and whatnot. So there's a lot of development into the system, but we do encourage now for the researchers to come in, and we are now proposing to the government to give us some money so that we can build what we call virtual environment so that anybody can go in and analyze the data with permission. With that, I should end the presentation, and thank you very much.
Thank you very much, Doc. Can I ask the next panelist to have his 10 minutes of presentation?
This is next. Okay. Good morning, Honorable Deputy Minister of Health, Dr. Lee Boon Chai, distinguished guests, ladies and gentlemen. My endeavor in the next 10 minutes is to convince you that technology can actually provide a lot of value in the healthcare system without having to make fundamental changes to the way the healthcare system is structured. Before I do that, let's quickly examine in the last few years some of the winds of change that we have seen in the healthcare industry as a whole, if you look at it. Starting from the right, acute care has been under a lot of pressure in many countries because the paradigm has changed. It no longer is the expectation of the patient that I should come to you, but rather the expectation is deliver me care where I am, which is what I call as care anywhere. At the same time, especially with the elderly people, the need for home care is rising very rapidly. I just saw a report yesterday which says globally the home care segment is looking at a growth of something like 14 to 15% CAGR, which means that in the elder care and the long-term care segment, that is the fastest growing segment for a variety of reasons. Especially in Asia, it is so because of the stigma associated when one sends their parents into a long-term care facility like a nursing home or an old age home. It's almost like sinful for someone to do that. Because of that and also some of the other factors which we can talk about later. And then there is residential care, which is really the last line of defense. And that's now coming up because a lot of countries globally and in the region are going through a demographic shift. Singapore, for example, 25% of the population will be over the age of 65 in a few years from now. Consequently, the healthcare budget is going up. Likewise for Australia, likewise for Hong Kong. And not very surprisingly also for China, which is expected to have 440 million people over the age of 65 by the year 2050. So just imagine the burden of elder care on the healthcare systems. There is a choice to be made of taxation and building nursing homes versus doing home care and day care, and how do you co-opt the family and so on and so forth. And lastly, mobility. Mobility is at the opposite end of the elder care spectrum in many ways, because mobility is something that all millennials identify with. My own daughter wakes up in the morning and the first thing she does is turns over to the bed and picks up the phone to see who's messaged her in the last 8 hours that she was sleeping. And that means that the way millennials consume information and the way millennials deal with information is changing. They expect the mobile to be the first line of defense. Consequently, as they enter the industry for healthcare services, you have to respond to that. You have to make information available to them in the manner of their choosing and not the manner of your liking. So these are some of the things that we are seeing in the industry today, and these are all ubiquitous and pervasive. These changes are here to stay, and they will impact the way we lead our healthcare services into the next generation. How do we do that? How do we respond to some of these? So one of the things that we have done is we look at delivering care anywhere, or rather enabling healthcare services providers to deliver care anywhere. So just take an example. Let's assume that there is an oncology center in KL, and it has all the super specialized physicians and the surgeons and all of them available. How do you make the maximum utilization of their capability and expertise throughout the country? And that is possible if I could project their capabilities into the hinterlands, into the villages, and into the remotest corners where the first line of defense, which is the primary care physician, is then trying to help a patient into the healthcare system. So how do we do that? It is done through a few technical things which I'll try not to talk of. I try not to use a lot of technology words and jargons in explaining some of these concepts. So there is this thing called the IoT, or the Internet of Things, which is enabled biosensors, and there are apps, and we can do assessments and activities at the site, in the home or in the clinic of a primary care physician, and we can do teleconsults. And on the other side, we have the clinical decision support, the real-time alerts, and the analytics related to outcome, which the speaker just before me also mentioned. So we can do all of that without, just imagine, without incurring the physical cost of travel or setting up infrastructure in the remote place. So you could technically have a patient in the primary care physician in, let's say, Johor being teleconsulted by someone in KL, and then based on a teleconsult, you could bring that person over to KL if needed, and that too, by the time they come here, the information is available to the physician. One of the biggest frustrations that most patients have is as they go through our health system, which in most countries is extremely disjointed, there is a primary care physician. From the primary care physician, you go to a specialist. From the specialist, you go to a surgeon. And from the surgeon, you go to a rehab. And from the rehab, eventually you do come back to your family physician or the primary care physician. And at that point in time, the patient, having traversed through the entire healthcare system, has this unfortunate experience of having had to explain to every physician at each time what happened to him or her. And that's very frustrating from a patient standpoint. And then on top of that, they have all these stacks of reports that they carry along at each stage. How might we, in that case, use technology and bring value into the system by simply enabling a referral network, which is, for most practical purpose, I would say EMR agnostic, which means it does not depend on who uses what EMR, but is still able to take that information, push it around in the healthcare system in that continuum, and making sure that the care is delivered appropriately by each person in the healthcare system. And I think that's the value we are talking of. How do you manage the patient data? How do you manage the patient experience and eventually the outcome in a seamless manner using technology? And that's possible today with mobility, with cloud, and with remote patient management, some of these softwares that can be implemented today. We also discussed about artificial intelligence. But before I talk about artificial intelligence, it's a very popular point of discussion in most forums these days. The point that I want to talk about is today, whether we take Malaysia or we take any other country in the world, the biggest stress is on the availability of nurses and nursing care expertise in every health system. Most of them will tell you that their nurses come from a certain country in Southeast Asia. Right? And that's, I go to Saudi Arabia, I go to Dubai, I have been in Africa, I've been in other countries, including Australia and other places. They are all from another country, which means you have lack of skilled nursing expertise in the country. Now just imagine, what does a nurse do in their daily task every day? They are going back and forth to the patient's bedside a few times and coming back. And many a times these visits result in having to record some data or the other. And then they either record the data on a piece of paper, come back to the nursing station, or use a computer on wheel and then enter that data into the system. But what if I could have that nurse interact with the back-end systems through a voice interface? This is what we're trying to do in what I call internally as Kill the Keyboard initiative. In my view, the keyboard is the most inhibiting factor to productivity in a healthcare enterprise. What if the nurse could just talk to a mobile and say, I want to move this patient from this bed to another bed, and what it does, in the way we have implemented it, there is a Google Voice recognition in the front end. It then goes in, recognizes that voice, converts it from the voice to the instructions into the HIS or the EMR at the back end. And once the patient is moved from bed 1 to bed 2, for example, then it comes back and says, hey, I have done it. And then the Google engine again translates it from text back to speech and tells the nurse that, yes, I have done it. This could be applied for a lot of the scenarios that we have spoken on the slide. For example, the bed status, the vitals capture. Today in Australia, one of my customers, what they do is they actually use the vitals by the bedside of elderly patients, and they just take the vitals, and those readings are transmitted through a Bluetooth connected to an IoT, and it directly goes into the EMR of that patient. What that does is, per patient, it saves about 2 to 3 minutes of data taking, entry and re-entry, avoids a lot of human errors and so on. So this is what is the power of a speech interface rather than a keyboard interface. And come back to what I was saying earlier, which is I want to kill the keyboard because that is what inhibits people from interacting with the application. If you ask, okay, I was waiting for the bell there. So if you ask a doctor, any doctor will tell you their greatest gripe on technology is that they have to use unusable systems. Usability is a big issue. But with voice, suddenly usability is not an issue anymore. Just imagine, the other technology we have is what I call as interactive EMR. A doctor meets a patient and says, well, looks like you have a broken leg. I want to send you for an X-ray. Meanwhile, you have a painkiller. As the doctor turns around, if the ambient speech can detect that and put that into the EMR record, all that the doctor has to do is to look at the scratch pad and say, well, that's okay. Everything is fine and accept. That is available today. We deliver that today. And look at the kind of productivity that increases and the value that it brings into the system. And that's what I submit to you technology can do without being very invasive in many cases. So what do we wish for? We wish for superior patient engagements for our customers. We wish for improved outcomes. And in all, a happy healthcare system. Thank you very much.
Thank you very much. Can I ask the next panelist to speak for 10 minutes? And I understand there's no restriction or limitations to what you want to say.
Why so special? Bismillahirrahmanirrahim. Assalamualaikum. Very good morning. Thank you, Mr. Yong. Yang Berhormat Dr. Lee, fellow speakers. Actually, first of all, I would like to thank the organizer, Kingsley Strategic Institute, for inviting me to share my thoughts. I think you will look into the term of the theme, which is talking about outcome and also values, and also in the changing healthcare landscape. I think my task is actually to tell the audience what are actually the role of the pharmacist in the healthcare system. Are we part of a healthcare system, or we are an integral part of a healthcare system? So, under this session, we are talking about a value chain, a pharma value chain. My colleague will talk into the manufacturer side, but I'm more on the patient, on the side of the patient. So, in that aspect, being in the UMMC for 35 years, I have no problem working there because we have a healthcare team. Everybody knows, what are the role and how to function. For example, if you talk about medicines, there is such thing as medicine management. And this medicine management involves 4 processes. It started with prescribing. It follows by dispensing, and then you're supposed to administer, and you're supposed to monitor, and then the cycle starts. So it is very important that this teamwork will at the end give value to the patient, because the patient is at the heart of the action. So if you look into that, then we'll see that the role of the pharmacists have changed. It's no more drug sellers. There are 3 roles of a pharmacist. Because we are trained, and number 1, we are medicine experts, meaning that all the 4 years that we go through our what you call undergrad program, a lot of emphasis on medicine, into technology, and so on and so on, including the latest technology. That's why in my hospital, previously, I'm retired already, I started the pharmacy information system throughout the hospital. And it's actually everything that covers the medicine management. In fact, we also started electronic prescribing that actually goes into the system. I'm sure my colleagues, they are here, They are here, knows about things that we have done. So what I'm trying to say is, it can be done. So the role of pharmacists is very important. And the other thing is that we have to touch about policies here, because I think YB also talk about where we have to admit that that this is our healthcare system. We are not complaining, okay? But how do you survive in this? It's all disjointed, isolated. A prescription from MOH is not valid in non-MOH facilities, etc., etc., etc. And this is not a good thing for the patient. So these are things that, as far as medicines are concerned in this country, we already have the Malaysian National Medicines Policy. So we are very clear in terms of our pharmaceutical sector, or even management of medicine. When we started this in 2006, okay, it has evolved. And in this policy, it covers a lot of things. Number one, governance in medicine. Okay, that means we have good governance and so on and so forth. Secondly, we talk about quality, safety, and efficacy of medicine. I think Mr. Leonard will look into this because this. But the only thing that I can say, all medicines are registered in this country. All. Meaning, there is quality, they are safe, and also efficacy for medicine. Yeah? The third point is access to medicine. These are the things that covers two areas. Number one is availability. Okay? Is it medicine available across the board? The other one is affordability. Also another issue. So these are things that trigger to a lot of current issues. For example, the national pricing, healthcare financing, and also the use of generics. It's all covered in this policy. Okay? And then we talk about the quality use of medicines. And this is very important. Okay, I'll give you a good example. Do you know that the biggest problem as a healthcare provider is why the patient is not able to take a medicine regularly, even once a day? Why? Even once a day is very difficult to get compliant. More so if you have more than one. So this is thing that the pharmacist has a role to play in terms of making sure that we talk about how to make sure that there is compliance. WHO recorded that 50% of patients are not taking medicine. 50%. So you imagine if you have how many billion of budget that you have, and the patient actually didn't take the medicine. At the end of our medical treatment, which involves medicine, by right at the end of that, the patient should take the medicine so that we can do a follow-up. If you don't take medicine, how do you know that it works? So these are things that actually a pharmacist have to play a big role. Yeah? And then we are talking about patient education, empowerment. The government have done a lot, My colleague in the government have done a lot. Have you heard about Kenali Obat Anda program? Have you heard about Duta Kenali Obat Anda? These are all very good programs. But as I say, it's still something that need to move. How I wish the Kenali Obat Anda program and the Duta Kenali Anda program should involve the community pharmacists. Then you can sustain that. What we are saying is that you can start all this, but it becomes sort of patches. It's not continuing. So if you look into the community pharmacists, they are actually in the community, and they can serve, and they are there from morning to night and so on. So I think this is thing that probably we can move into that area. Yeah? And they also talk about partnership and collaboration. Okay, so we are talking about now we have a two system, and I'm sure YB also talking about how to start this partnership. I think this is a step towards integrating. I don't think we have a choice not to integrate the whole system because the system will not work. We have to integrate. All right? How I wish, for example, when you talk about empowerment, where the patient is actually holding their data in terms of medicine, for example. I give you an example where a chronic patient, they must have a list of medicine that they are. By right, we should empower the patient to have that list inside their handphone. Okay? So that when they go anywhere, where they get where they meet doctors, anywhere, they can show. Right? And, because it is owned by the patient, then you don't have issue with personal data and so on, transfer, So these are things that we should do. So, I just want to introduce another term. We call it pharmaceutical care. Have you heard the word pharmaceutical care? Pharmaceutical care is not about pharmacy. Pharmaceutical care is about the medicine management that I mentioned earlier. That is the delivery of pharmaceutical care. It involves doctors, pharmacists, nurses, and all allied sciences. So it's something that I can share with you. And last but not least, in terms of the competency of the pharmacists, rest assured that we are, like the doctors, we are highly regulated. Okay, you want to practice a competent pharmacist, you need to follow a benchmarking. You want to practice, you must have good dispensing practice, good compounding practice, etc., etc. So, I think in terms of that, we are there already. And lastly, just want to share with you, because I'm one of the members of the pharmacy board. Okay, currently we have more than 17,000 of registered pharmacists inside the register. Out of that is about 13,000, almost 14,000 that is actually practicing. Okay, so this is the number of pharmacists that are now available to serve the country and nation. And for your information, last point is that the pharmacists are involved in the promotive care, preventive care, curative care, rehabilitative care, and also palliative care. So please consider the role of the pharmacist. Thank you very much.
Thank you, Amrahi. You've got lots of experience, 35 years of experience. I'm just wondering, here we are talking about artificial intelligence, when sitting next to me is the natural intelligence of 35 years of experience. And I was just wondering whether people have tapped into your expertise and doing a PPP with you some stage. So the next panelist, Leonard, you are a manufacturer as well? Okay.
Thank you very much, SK. YB, guests, thank you very much and a very good afternoon. I'll be talking on probably the first start. The topic that was given was to talk about supply chain. And really, as a manufacturer of pharmaceuticals, we're the starting point of the supply chain. But it gets slightly more complicated than that. But let me start off by just talking about two anecdotal stories. Back in 1997, I had a 3-year-old son who had a habit of waking up at 5 o'clock in the morning. And his favorite program on TV was a program called Barney. So he'd wake up at 5 o'clock and sit down on a couch. We were on a holiday in Langkawi, so he was sitting on a couch watching this program, and somehow or other, he fell backwards and hit a glass table and managed to cut his ear. So the hotel was very good. It provided a nurse within 15 minutes, and the nurse said, look, there's no private facility that's open in Langkawi at 5:30 in the morning. We would have to go to the government hospital. So we did. And there was a young doctor there at the time, and he stitched up my son's ears. So it came to paying the bill. Malaysian IC, so I gave my bill. He was given the bill, and I was quite shocked. It was 1 ringgit. Okay, this is 1997. 3 weeks later, I was back in KL, and I had to have the stitches removed. So I went to the pediatrician in a private hospital in KL. He had a long look at the stitches, and out came a magnifying glass. He had another look and said he needed a consult. And the consult was with a plastic surgeon. Turned out that houseman or whatever in Langkawi had actually got a medical degree from UK and did a specialist degree in the US in plastic surgery. And when he came back to Malaysia, because my son was very young, he wanted to ensure no scarring, So it is a special type of stitching that my pediatrician couldn't remove. So I paid 1 ringgit to put the stitches in, and I paid 800 to remove. Okay, so that's anecdote 1. Second anecdote happened just 24 months ago. After turning 50, I started getting light sensitivity and as a result migraines. So I did the whole gamut of testing, proved there was nothing wrong, and they gave me medication for migraines, which worked fantastically well. I paid 120 ringgit for 2 boxes. Each box had only 2 tablets. So 4 tablets, I paid 120 ringgit. And because of the incidence of migraines, I ended up having to go to a private pharmacy, which shall remain unnamed, and ask for the same thing. Can I have 2 boxes of this? And I showed him my prescription. He filled the prescription and he said 60. So I gave him 120 because that's what I paid because I thought he meant 60 ringgit a box. And he said, no, 60 ringgit for both boxes. Okay? And therein lies the conundrum that we have in Malaysia. The disparity in pricing that occurs between the government side, which if you ask me, is not sufficiently user-funded. Okay, I'm not talking about government funding, I'm not talking about budget. I'm talking about user funding. And of course, on the other extreme, you've got the private sector side, which due to various reasons will have to actually being profit driven, obviously, in addition to serving the patient, also looks at different ways that they can actually gain profitability to fund the cost of the hospital. And it's not, as I said, the concept, going back to the original thing about supply chain, where are these price distortions occurring? Are they occurring at the manufacturing side? Are they occurring at the supply chain side? Almost 100% of the multinationals operating in Malaysia all use third-party logistics. Okay, there's very little between them as one step between and up to end-user side. That's for the private sector. Now, to give you an idea of scale, you've got about 2,500 pharmacies in Malaysia, around about 5,000 practicing GPs. Okay. Now, if you put in the government side, you've got a fair number of hospitals throughout Malaysia and more than 2,500 clinic kesihatans throughout Pan-Malaysia, including Sabah and Sarawak. So the supply chain to service this is actually quite expensive. All right. To give you an idea, the costs for logistics, in the case of Duopharma, the company I represent, anything within a circa 80 kilometers, we handle directly. That means we deliver directly to the smallest GP, etc., for the private sector. Anything outside, we are forced to use third party. And one of the biggest issues we have is to ensure good distribution practice among third party logistic providers. I've had situations where transporting a small load of paracetamol, I got a call from the pharmacy, said, thank you very much for the fast delivery. It's lucky I had a shoe shop next door because the same lorry that delivered the Bata shoes to the shoe shop delivered my paracetamol. Okay? And that's a problem. It's a problem. We don't have specialized logistic companies. There's no requirement for it. So what the regulators do, they do another way where they stipulate certain standards that are supposed to be met. Now, these standards, unfortunately, put pricing pressure. But to give you an idea, between manufacturer, assuming one delivery company, and end user, you're looking at anything between 12 to 17% uplift on the drug prices. Okay? Now, with the government side, the supply chain is slightly different. About 50% or 40% goes through a concession agreement, and around about 50% are direct deliveries. Now, I'm often asked the question, is this the most efficient way of doing things? It really boils down to a policy decision. Direct delivery to clinic kesihatan and hospitals, if you ask me as Duopharma, we're the second largest pharmaceutical producer in Malaysia, my answer is I would love it. And I will give the government a saving if I did it immediately. But the smaller producer of medical devices, based in Sungai Petani, is not able to have that level of reach. Okay? So in a way, last mile delivery is a policy decision. You may end up with anti-competitive type of practices if you allow the manufacturers to deliver direct to the end user. If the question was asked to me, YB asked me the question, I would say yes immediately, that I will do it. But I also know at the back of my mind, I'm saying yes, I'll do it immediately because it will kill off a few of my competitors. And this is why my view tends to be a little bit unpopular, why I think the last mile delivery, especially within the government sector, which is primarily the largest consumer of generics in the country, is actually good to be managed by an independent party, whether it's government, private, etc. But that last mile delivery ensures that on the one hand, you get the right level of stock, etc., catered for all the clinic kesihatan and hospitals. The problem is less about the hospitals. It's really about the clinic kesihatan. So that's where supply chain comes in. And I think this is where it's really a policy decision that really bears a lot of study. Okay. The second part is about manufacturing. Now, how can we ensure, from the manufacturer's standpoint, that drug prices at point of manufacture becomes more cost-effective? I think the starting point is to realize that the pharmaceutical sector, like Amrahi said just now, is one of the most heavily regulated sectors in the world. Let's face fact one. At 33 million population, we are not big enough to manufacture lots of products. We do not have scale. And the patient's money required to make sure that you develop export market to get that level of scale will take easily 7 to 10 years. So if you're going to put up R1 billion building up a huge facility and you're only going to use 5% for the Malaysian market, then you have to ask yourself, is that really what you want to do? But that doesn't mean that we can't be self-sufficient. There are other ways of doing it. You know, we've made the mistake. I think HK asked me just now about making a comment about vaccine. We've made this mistake before. We tried to build a vaccine facility in Malaysia. Now, if you knew anything about vaccines, there's no such thing as a vaccine facility. It's a facility that makes one vaccine. You don't build a factory and suddenly 20 vaccines come out of it. Where we should be looking is potentially fill and finish, and risk mitigating by ensuring for every vaccine we look at, we have minimum of 3 global suppliers. That way you get the cost benefit of a scaled plant, and you have self-sufficiency in ensuring that you can do the fill and finish with a range of companies. That's as far as I'm going to say. But one of the things I do want to bring up is what I call predatory pricing. As a local generic player, this is one of our biggest issues. A multinational Indian company opened a facility in Johor. They announced it in 2010. Since they announced the investment in 2010, they have now come into being. The price of that particular product has fallen by half. Okay? But what did the multinationals do? They dropped prices even lower, then half. Okay? Take another product. There was erythropoietin. It's a product that Duopharma itself, when we did the economics, the price per vial was 35 ringgit. 1 year after we announced that we were looking at it, the price per vial fell down to 15. Now, the only reason these prices fall is because of the advent of generics or biosimilars. But the problem being that we find that there's predatory pricing to try to ensure that developments that are being done get stopped. Okay, and already we're seeing in erythropoietin, prices dropped to almost the lowest in the world, globally. And after we went ahead and we didn't stop, the multinationals are slowly rising the prices. So the latest standard I heard, prices have gone from 15 to 18 or 19. So it's this sort of predatory pricing that again falls back on the policies that the Ministry of Health develops. Do you want a vibrant pharmaceutical industry? If you do want it, and if generics are proven to be able to bring down prices, then some level of generic-friendly policies have to be put into place to make. And you don't make U-turns. We've seen this. We've invested in biologics in Malaysia. We made so many U-turns. Vietnam invested 1-2 years after us, and their company on biologics is about to go for public listing in Vietnam. because pharmaceuticals is not about, especially manufacturing, is not build, get a good idea today and 3 years from now you have a plant. Get a good idea from today and it's probably 6 years before you even see cash flow. And that's the level of policy determination that we require in order to be able to introduce more generics, more biosimilars into the country. With that, thank you very much.
Thank you very much, Leonard. Very insightful. I'm just wondering, with all the experience that you have got, you have managed to find a way of channeling all this information back to the ministry or to the policy makers?
We deal primarily with the national MPRA. Okay, so what happens is MPRA every year has roundtable discussions in order for us to feed our input in. But I think you have to understand that MPRA look at it from a patient angle, safety. As far as they're concerned, it's really all about quality, safety, efficacy. So some of the things that I'm talking about are policies that have to be done at an apex level. And this is very much what Amrahi was saying, that we've got a national medicines policy, but it's patient-facing. We need to have a policy that looks at how do we really want pharmaceuticals to develop in Malaysia in total. And that might require a national healthcare policy.
Right, okay. And then you've got to find a platform to get everybody together and something which Khadzir can actually do, get all the people together. And I think you did mention earlier that there's a shortage of nurses, and then I was speaking to you and say, no, there's a surplus of nurses in Malaysia. Yeah. I would like to open the floor to a Q&A. If you've got any questions, please feel free to ask the panelists. No questions at all? Or you're just a bit hungry? Okay. The usual thing, state your name, where you're from, and who you want to direct the question to, or is it going to be a general question? We'll take 3 questions at the same time. Okay.
Yeah, thank you for giving an insight into the...
ladies first or... Ladies first. Ladies first. Oh, you're such a gentleman.
Yeah, thank you, the panel, for providing an insight into the landscape that is called optimizing out.
Oh, can we have your name?
My name is Dr.
Okay.
Direct these questions specifically to our doctor. Who is that is in charge of informatics and analytical
the double doctor.
Data? Yeah.
Yes.
MOH. I think it's fantastic what is doing by the ministry, health ministry, on the ground of data collection, data management. But I would like to draw the attention to how
there's something wrong with the speaker, the mic. You want to come to this mic? It's not me trying to shut you up, it's just the mic.
Yes. Yeah, continue.
Yes.
So my concern is how to optimize the data collection and the data, the whole host of data, to empower the client or the patient to own it. This provides a policy feedback. My own personal experience dealing with government hospital, ranging from general hospital to UKF to Selayang Hospital, that because I help a lot of patients, where those cancer patients, those brain tumor patients, they are not allowed to even to draw out their own MRI report or the image. Secondly, I think it's only UH allow it. So, please, I think with all this policy in place, with all this fantastic work, I think effective and optimizing data has to be done, avoiding all the bureaucracy, avoiding all the unnecessary core KPI or all this change. And I think to link with value change, that is a very important how to see from the perspective of patient. I feel very sad because it causes a lot of, and it has impact on the healthcare where the patients has to spend so much extra money, to do it outside, first thing. Secondly, in terms of data management, until now, the general hospital does not build out even data management or to cut across between the departments. That is the feedback because I'm helping a patient who is 70 years old that she has been sent. She has been seeking treatment since March, And until November, even the cancer is detected at the 4th stage, and still she's not referred to see a doctor after 2 weeks appointment given. And even that, oncology and the necessary steps to be taken are not arranged until I present myself to speak for that woman. Similarly to the patient that is in UH private, that I help to speak to the specialist in the private specialist center of UH, and she's referred to the public, but her brain, the skull, has been opened up on and off 6 times because of misdiagnosis, misjudgment, and also penetration of bacteria. And how could the patients, the general layman, be protected?
Dr.
This is a part of information I provide on the ground, and I hope information data collection has to be very reliable and also down to earth and back to put it in real practice that is with patient at the center. Thank you.
Dr. Tan, you are from University Malaya?
No. Presently, I'm a researcher. Thank you.
Researcher, okay. And those are very fundamental issues which I think you can address. But before you address, can we take another question? Dr. Milton, is it? You have the mic.
Can I just ask, what value do tender agents in medicines procurement bring to patient care?
I assume that's directed to Leonard. Okay. So we have a left and a right. Right, you want to answer? One more question. Okay, one more question. We'll take 3 questions.
Yeah, I'm Dr. Bhaskaran, Ghana Bhaskaran, too long. I'm the president-elect for MMA. My president is here, but I think since he will be the past president in 3 months, asked me to speak. There are a few things. One is about regarding the pharmacy our president, very good friend. Quickly, but Dato' Lee, always you need to listen, because this is what the former government never did. So you got to sit down and listen for a while. The pharmacy guys, we have no problem about dispensing separation, but we will not give up the dispensing as long as the fee schedule does not come in place. I want to mention this because you're always asking about separation. We want to separate. I want to separate. We want to separate. Why should I have the headache of medicine? But as long as you give the fee schedule, which is being held for 20 years, we are not going to give up. We will not give up. That is clear. Today also the minister said, obviously it's all politics in this country. Every decision is deferred because of politics. Unfortunate, but that is what it's all about. Okay, doctor, I know what you're coming to. I'm an ex-politician. Not now. You were long before you, I stood for election.
Maybe not so loud about you being an ex-politician.
Yeah. I was a DAP politician. Okay, thank you. Okay, the other thing is about this Dr. Tirupathi. Thank you. I see this future is all about senior care and whole care people. In this country, doctor, no, you're not Dato yet. Don't become a Dato. Too many. Can't even mention. Everybody I know is a Dato now. So I tell you, the worst is the Indians. So one particular state gives la Dato. Listen la Dato. Sorry. So
you got a question for?
Yeah, I'm asking him because the government is no use. They are promoting all this aging, living care, and all that. The government itself has to come out with clear policy. Luckily this country consists of Malays and, they look after their parents. But don't think it can be a possibility in the future. Your rules and regulations have to come in place. The children must be made to care for their parents, like Singapore. Thank you, sir.
I'm sure the question is not addressed to any of these panelists because they are not the government.
No, how do I know?
Okay.
I mean, it's all, nobody tells the truth.
Doc, you want to take the first...
Excuse me.
Sorry, one more.
Can I ask a simple question to the pharmacist?
Oh, it's going to be a difficult one.
What do you think is the value, after all we are talking about value, the value of value pricing for drugs as is being practiced in UK now? Value pricing.
Can I ask a question as well? This is an open question to the panel.
It's a fish question, okay? We'll just stop that.
Last one. Just coming from an outsider's perspective, what are your thoughts?
Sorry, I didn't get your name and your
I'm Sheikh from investment company. Just what are your thoughts on this? Does THC have a space in pharmaceuticals, industry in Malaysia from a pharmacological perspective, from a business standpoint. Despite being we have the drug laws and everything. What are your thoughts? Because you look at MNCs overseas, and there's a big drive towards decriminalizing and using CBD, THC-based medication, and there's big money there. So, what are your thoughts on that? Does it have a position in Malaysia moving forward as we try to grow the pharmaceutical value chain and business in this country? Thank you.
Okay, thank you very much. I suspect that many of these questions are directed to the YB really, rather than the panelists here. So, Doc, you want to be the first?
Yeah. Thank you for the question, Dr. Tan, is it? Yeah. I hope I remember your question very well. There were too many of them. Yes, I'll do that. But that's one thing I learned about this presentation. Next time present to the pharmacy group, then you'll be spared a lot more questions. Okay, your first question is about utilization of the data. This is very much needed in the Ministry of Health. One of the challenges that we have with the research component for the data is everybody wants to take the data out of Malaysian Health Data Warehouse. And that becomes very tricky because the moment you give them the data will walk everywhere. So in the interest of the patient, we won't allow for such thing. So what they have been doing with us now is they come to our center and we give them access to the system and we close the access once they move back to their place. What we have in mind, and the plan is to ask for the development of what we call a virtual environment, where they can log into the environment and they can get access to data, and they can also bring the data and they can use the technology that we have, and also bring their own technology. So that is to make sure that the data stick inside the data warehouse and they are free to do the analysis. That is number one. So it depends on you how you want to propose for the research or analysis of the data that we have. Does that answer your question? No? Okay.
Or their own relevant data, they couldn't have access. Okay. Doc, I think this is a very fundamental issue which I think you would have addressed in your data bank already. It's something very simple. Can I suggest that we take this offline? That you have a chat with Dr. Tan later?
If you like that, okay.
You don't mind, because I think in the interest of time, we have quite a number of questions that needs to be answered. Is that all right with you, Doc?
Yeah, Dr. Tan, he's suggesting for a private moment with you.
Okay. I tell you what, why don't I just go to you, because you know the question is the question you got to answer.
Yes. I think the question was on elder care policy and making the children of the elderly responsible for their care through a legislation. As you can see, I'm neither in politics nor in policy making, so I can't answer that. But what I do want to add to that point is, today there are 3 or 4 countries which are recognized for their elder care policies in the way they have delivered elder care. NHS in the UK is one of them, the US is the other, Australian, New Zealand, and of course Singapore as well. What we can do in the way we provide technology is we run across 11 countries with customers in elder care. So when we implement some of these technologies, they come with these built-in standards. For example, there are 162 or 164 care plans that the NANDA in the US talks about, and all those are available. So those standards we can provide to elder care operators to ensure that there is a consistency of service quality across their various elder care facilities. I think that's something that we can do from a consistency and uniformity of service delivery. But policy making, I would probably defer that question to better people.
Right. Amrahi, you want to answer? You've got a question to answer? No, you have to answer.
I always expected that question from my doctor colleagues. I think in terms of dispensing separation, I think I have to be very clear on MPS then. Okay? The latest that we heard from the minister is that there is no polemic. As far as YB is saying is that doctors, this is their role, pharmacists is their role. There's no polemic. Okay? The issue is how are we going to move forward? Okay, that's the issue, how to move forward. And for this to work, okay, the only thing that it will work is from the eye of the patient. What will patient benefit from all this? If you look into what is going on in terms of structure, okay, if you look into the healthcare structure, we have a primary care, secondary care, and tertiary care. Since we have a dichotomous state, so you have to divide into two. So you have 6 sectors. Okay? And dispensing separation already existed in 5 out of 6. So that's why it's important for us to realize that there's no issue. I don't think we are very clear that the roles are there. So the patient must benefit from all this. And we're only talking about safety. I did mention about delivery of pharmaceutical care. I did mention about medication safety. It is very important that we address this. Being member of the National Patient Safety Council, I feel obliged that that a lot of things not being done, as mentioned earlier. That in terms of safety, we are not collecting medication errors properly. It's really something that I'm not going to touch. Okay, but if you have a system, probably in my hospital previously, we can address all this. Okay, because we can address all this. So we felt that that wherever it is, it must benefit the patient. Okay, so there's no. So if my doctor's colleague says that this is the prerequisite, we will support the prerequisite. Indeed, we did support the doctors for their fees, and we put it in black and white that we supported. So it depends on the government when. But I feel that the government should at least form a task force. Form a committee, whatever. Let's discuss, open. And my last point is, think from the patient point of view. It's not about pharmacists and doctors. That's my thing. Thank you.
Okay. Can we just have another 5 more minutes to go, and then Leonard will wrap it up? Okay.
Yep, sure. Okay, I'll be quite fast. First question, tendering agents. As I said just now during my talk, I tend to have some pretty unpopular opinions. First and foremost, how much does tendering agent earn? Generally, when I entered the industry, it was as high as 7%, now it's down to 3%. Out of that 3%, they get taxed about 1.4%, so they make about 1.6%. Is it beneficial to the industry? In a way, it is, because I've got a sales force of 20 people handling 60% of my turnover, and another team that handles the private sector, 100 people handling 40% of my turnover. So obviously it means as a manufacturer, I need to take on a much lesser number of salespeople to get the same level of coverage. Having said that, at Duopharma, we have our own license to supply directly to the government. So the policy that we have taken for new products, we supply directly. For some of the older products, we continue using these tendering agents. The lowest rate I'm paying is probably 2.2%, and which means they make roughly about 0.8%. So there is a savings as far as the manufacturer, which we are able to pass on to the government. But I think the people who've been most vocal about this tend to be the multinationals. They say, why do we have to pay 3% to supply to the government? My answer to them is that if I want to supply in Europe, first they audit my facility, then they audit my supply chain, then I have to do registration in their country. And then when I'm done all that and I want to ship a product to Europe, they ask for a pre-arrival inspection that has to be a European licensed company. And I can assure you it's not 3%. You can practically replicate that in the US. Okay? So that's why I say sometimes what you read in the press is not really presented in a way that is really factual. Okay? So my view is, can we do away with the tendering agent? The answer is yes, we can. But be prepared, however, that it may have an adverse impact on the overall healthcare bill for the government. Prices may have to go up because all the private sector companies who've been using agents will then have to incur the same cost to be able to do the monitoring of orders, etc., 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 etc. Okay, so that's just one dimension. The other question I'll just touch very quickly is value pricing. Be very careful about value pricing. It's being tested out in the UK. There is a new development that's happening where pharmaceutical companies are saying to the government, let's not fix a price. We'll give you the product for free. But depending on success, that's when you pay. Okay, it's almost like a success fee basis. There's all sorts of ethical issues around it. But it's being tested out at the moment in UK and in some places in the US as well. It's again a policy decision. I think the system that we have and the healthcare provision that we're able to do it given the budgetary constraint we have is excellent. Obviously, there are certain areas. The problem that I think we're grappling with at the moment is not that incidence rates like cancer have really gone up, but it's more the diagnosis is a lot better now, etc. So a lot of the double digits you see, I think, is driven by better diagnosis as opposed to actual incident rates go up. The problem we're facing is the cost of new medication coming down the pipeline. It's really, really high. Some of them are, I think we've done a lot of work opposite hepatitis, for instance, and we managed to bring the price down, which is great. But you know that if I calculate the number of hepatitis C patients in Malaysia multiplied by even the new price we have, it will take up almost 35% of the healthcare budget of Malaysia. Just to sort that level. And this is where I say that I think we have to move to a more user-pay system. We have to start putting more into the pot to assist the Ministry of Health rather than just saying our taxes will pay for it. Yeah. Some sort of policy change will have to occur. Lastly, this is probably a friend at the back used nice terms. He was talking about marijuana legalization in Malaysia. Okay. Before it became popular, we were working with a company in Tasmania. They had the first legal marijuana farm used for therapeutic needs. I think it's a policy decision again that needs to be made, and it has to be made from the point of view from the patient standpoint. And I think today or yesterday, the US FDA actually approved the first ketamine treatment for depression as well. I mean, we all know ketamine helps depression, but it's the first time that it's actually prescribed for humans as opposed to horses. So I think there is a change that is happening. Should we be the first one to jump on the bandwagon? I always say no. We're not that big a country. Let's look at what the experience is overseas and make a value judgment as opposed to just saying because Thailand is doing it, because US is doing it, let's all follow suit as well. So my view is let's take a step back, evaluate the circumstances, look at the science, and look at it from the point of view of patients. Okay? Thank you.
Thank you very much, panelists. I think, Doc, you want one final word, right?
Can I go back to Dr. Tan? I think the question that you were trying to address was about primary data use, which is not what we do. We are dealing with secondary data use about the patient. If you're talking about patient care, you really have to go to the provider to seek for that assistance, not at us. I hope that helps.
Okay. Right. Thank you very much. We can't take any more questions because lunch is waiting for us and we're all quite hungry now. Can you please join me in thanking the panelists for sharing their insights?